begin, I'm going to welcome all of you. Good afternoon, everyone, to the pediatric team of the Northwestern University Faculty Forum. This is our largest forum so far. There's a lot of interest with pediatrics, I see. For anyone that I haven't met yet, I recognize a lot of faces here through our virtual info sessions that we've done. But I'm Daniel. I'm Assistant Director of Admissions here at Northwestern's Department of Physical Therapy. And I basically help with the recruitment process. And then I also help answer questions throughout the application process. And I think like 98% of y'all are applying this year, like this upcoming cycle. I see a lot of head shakes, and which is the PT Cast is opening up next week, which is wild. So I know a lot of you all are shopping around to see which schools work well with your interests. And of course, we hope Northwestern is up there. But so we're gonna go ahead and start with introductions. We have Dr. Theresa Moulton here. And I'm gonna go ahead. Do we have, is Colleen here yet? Or, oh, there she is, I see her. Hi, so we also have Dr. Colleen Peyton who is here. And then is Kristin here yet?
I think I'm right next to you, Daniel, in the pictures.
Right next to me?
Yeah.
Oh, there you are.
I don't know.
Okay.
It probably looks different to you.
I have a few screens. I'm admitting people in from the waiting room, and yes, a lot going on. Yes, we have Dr. Kristin Krosschell here as well. So I'm gonna go ahead and turn the floor over to them. I'll have them go ahead and introduce themselves. And you all, if you can include like how long you've been at Northwestern, your clinical practice, what you teach, your research focus, and then maybe a fun fact, anything else that you'd like to add. So we can go ahead and get started with Theresa, and then we'll do Colleen, and then we'll finish off with Kristin, and Kristin will go into talking about how the pediatrics rotation fits into the entire curriculum as a whole. So Theresa, take it away.
Great. Thank you, Daniel. I appreciate the opportunity to be here. It's nice to see all of you. As Daniel said, my name is Theresa, and I have been at Northwestern, well, originally since about 2003, but that started out as a graduate student. So I am an alum of the program, and I've been back in a faculty capacity now for the last 5 years. So this will be coming up on my 6th year as a full-time faculty member. And I don't see a regular patient caseload at the moment, but my clinical practice was always in outpatient, including outpatient aquatic therapy. And I teach in the lifespan curriculum, where you'll hear from Kristin, a lot of our pediatric content does live, as well as the neuro curriculum and electro therapeutic agents. And my research focus is really in cerebral palsy across from kind of birth to early adolescence, and thinking about physical activity and how motor control is different in kids with cerebral palsy and how we can treat that. A fun or interesting fact. I don't know. I don't feel particularly interesting at the moment because I don't know that I've worn non-athletic pants for the last 3 months. But something that I've been doing during quarantine that I appreciate more opportunity to do is just doing some gardening in my backyard, and appreciating the colors of spring and now summer that are emerging, and trying to find some happiness within my own space here. So I don't know that that's interesting, but that's kind of, that's quarantine life.
Anything that can bring a smile to our faces right now is interesting enough. So thank you so much, Theresa.
You're welcome.
Colleen, it's all yours.
Hi, everyone. My name is Colleen Peyton. I have been at Northwestern since July of 2018, so coming up on 2 years. Before that kind of leads into my clinical practice. I was at University of Chicago as a clinician for 14 years. And I've done pediatrics my entire career as a clinician. So I worked in the NICU, I worked in outpatient, in acute care, and in hospital specialty clinics working with orthopedists and neonatologists. So I got to do a little bit of everything in my clinical practice in Peds, which was fun. Right now, I also teach with Kristin and Theresa in the lifespan class, which is like kind of like our pediatrics course. I also teach in the neuro curriculum and some of the foundational courses in the first year. And my research focus is similar to Theresa. I'm also very interested in cerebral palsy, but more specifically, I work a lot on infant studies and looking at the way infants who are at high risk, meaning that they were born early or had a brain injury around the time of birth or any other congenital issue in infancy, relates to their long-term development and also their neuroimaging. So, and a fun fact about me, let's see, I live across the street from the Evanston campus football field, and we let people park on our lawn for football games. There you go. So if you ever need a place to park, my lawn is for rent. Or maybe if you guys are students, I would even let you have a spot for free.
So basically, Colleen is a saint, is what she just said. Thank you, Colleen, for your introduction, and we'll go ahead and have Kristin take it over.
Nice to see so many of you here this evening. So I've actually been here the longest, and I don't really know how long I've been at Northwestern. I was just thinking about that when Theresa was talking. I was like, I don't know the exact year I came, because I started, so I used to work way back at Children's, at the old Children's, and I was adjunct, and then I went to part-time, and then I went to full-time. So I've been around for a long time, and I was the only Peds faculty for a long time, so it's really exciting. I mean, we have a lot of associated faculty from outside that we should also mention. We have a lot of local clinicians that are part of our pediatric faculty. We're just the 3 core faculty. But then it was exciting to bring on both Colleen and Theresa into full-time faculty positions as well, so that we could continue to expand internally offerings as we've had more and more students in particular who have been interested in pediatrics. I teach in the lifespan curriculum, which is the pediatrics through sort of the across the lifespan, but and then the neurological curriculum and complex patients. And my area of research is a little bit different. So I actually work with children who have a muscle disease that previously had no treatment, and the children didn't do well and they didn't live long. And in 2016, one of the first treatments became commercially available after a lot of clinical trials. And so I work with that population through Lurie Children's in their clinical trials, and have been very busy sort of developing outcomes to assess motor function and change with the drug treatment that they've been receiving. And actually, I spent the entire day today on Zoom, more hours than 10 hours actually, as of now, because it's actually the week of our International SMA Research Meeting, which is the disease that I study. And unfortunately, it's the first year that it's virtual. It's very different than being at a real meeting with your colleagues. It's a very interesting experience, mind you. Anyhow, so that's sort of my background. My clinical background, I used to work at Children's. I've worked in private practice. I've worked in EI. Currently, I don't see any more early intervention patients. I haven't for a couple of years, and mostly just work on the studies through Lurie and teach at Northwestern. So to give you a little bit of background on our program, so our program pretty much, so we have one sort of freestanding course. It's called Lifespan 1 and 2. At times it's been just Lifespan, but it goes across 2 trimesters. The fall trimester we're now back to most of the Peds, I'd say 95% of the pediatric content, except for maybe a community screening type of visit, is in the fall trimester. And we use a lot of, like I said, local clinicians from Lurie or who work in private practice or in the school system to sort of help us so that we can have smaller groups.
And
That,
Kristin, sorry to interrupt. Is that the first trimester of the first year or the second
oh
year?
no, yeah, that's a very good point. Of the
Oh,
second year.
okay.
So you don't really have your real pediatric course until the second year. However, we do try to integrate, that's a good point, Daniel. We do try to integrate pediatric cases across our curriculum throughout all the other courses that you have across the curriculum. It's just that you'll get your sort of full-on pediatrics comes in the fall. It's not that you won't hear about pediatric things before then, but that's sort of when you get the most of it. We have a lot of opportunities where we have infant observation labs to learn normal development and sort of typical development. We have, we go to a local daycare to learn how to do assessments in infants and children. We do different types of things within the class, all related to like learning development across the lifespan from infancy through toddlers. We bring in a lot of babies and children for you to observe and sort of learn how to make observations on movement. And then we also then you also learn about atypical development and apply sort of what you've learned in typical development into some case studies with small groups, and while at the same time learning about a lot of different pediatric diagnoses and how you would assess and intervene with them. That's sort of the gamut of what, and then we also do a community screening. So in the lifespan series, you can choose to do a community screening in either a pediatric setting or an older adult setting. And so we have a couple of different opportunities that we've offered over the years. It varies. So that's another pediatric opportunity within that course. And then also just in like, in the neuro series, in complex patients, in a lot of your second year courses where you're starting to apply and do more application of what you've been learning after the basic sciences, you get a lot of cases that are actually pediatric cases that we utilize that have different diagnoses to sort of help you apply different concepts and learn different information across the curriculum. There's also the opportunity to be involved in, everybody in the curriculum is involved in a research project at some point. It's called our synthesis. And you have the opportunity also to select a pediatric oriented project of interest, which is typically led by Theresa, myself, Colleen, or one of our associated faculty. Jessica has also been very involved in that process. So those are sort of the basics, sort of the, I don't know if Colleen and Theresa have other things that I've missed. Oh, the one other thing is, I think in our neuro series, in the second year, you do actually, in the winter, you actually follow a patient through the trimester and you apply neuro treatment with like with a faculty preceptor in small groups, like 3 to 5 students. And if you choose a pediatric patient, you more than likely would go to the home with the preceptor because we do most of the children in their home settings. And we also think it's a good idea for you guys to learn how to, what's different in the home and what early intervention is like, or just even what it's like treating within a home setting. And so if you happen to choose a pediatric patient for that scenario, you can choose a peds or an adult patient, then that's another opportunity that you would see a pediatric patient 5 to 6 times with a preceptor, and then you would meet in small groups like every other week to discuss like follow-up and next sessions and stuff. So that's another sort of big place you can get some good pediatric stuff. And I don't know if Colleen and Theresa might remember things I haven't mentioned.
I think you hit the big points. I'd like to hear from you guys, like what some of the things are that you have questions about, and there may be stuff that comes up in our thought process hearing from you and what's important to you.
Yeah, for sure. And as you all start to ask questions, I want you to keep in mind, I see a couple of people. Yep, people are already using the hand raise feature. So if you're not familiar with the hand raise feature, you can go to participants at the bottom. Then when you click that next to your name, you'll have the option to do that. If you don't want to do that, you can type your question in the chat, or you could just raise your hand and say it out loud if you'd like. But we have multiple people right now who are raising their hand. I saw Cheryl's first. So Cheryl, we'll go ahead and get started with you.
Awesome, thank you so much. So my name is Cheryl Satlock. I am a recent graduate of the University of Michigan School of Kinesiology. And my question tonight is, I was wondering if you could explain a little bit more what Go Baby Go is and other pediatric volunteering opportunities that are available for Northwestern students.
So Go Baby Go is a way to provide sort of modified opportunities for mobility in children. And I don't know if you've ever seen, I'm not really sure why you asked the question, if you've seen the cars that come, but so typically you take an off-the-shelf power car for a child, and we modify and adapt them for children with special needs. And we individually adapt them to sort of fit their needs. So families apply, we have like an open application system, and they apply, and we've sort of averaged 1 to 2 builds a year. This year, unfortunately, both our builds were canceled because of COVID. But we're also at the Chicago Auto Show this year. So we bring in like 5 to 6. We tend to, some places do much bigger builds. We tend to stick with 5 to 6 kiddos, and we really try to individualize the cars, working with both the PT students and the engineering students. We usually have one build that's sort of a volunteer type build or through our synthesis or research project, and then another build that is sort of available as an opportunity through the complex patients course. And it's not to say that you couldn't volunteer any other time as well. But yeah, so we build cars to individually sort of meet the child and family needs. And then we're doing some research also to sort of follow up and assess some of the outcomes related to that.
That's wonderful. Now, is this available for free for families, or does it cost them money?
Currently, we have provided, the cars that we provided over the last like 4 years have been provided free of cost to the families.
That's wonderful. I've just heard so much about it, which is why I wanted to ask. Thank you.
Yeah, we're always looking for volunteers or like, you know, opportunities, funding opportunities, but we've been able to self-sustain with some really good support from our department.
That's awesome. Thank you, Cheryl, for that.
Can I add one quick additional piece about, I think you asked a little bit about it, Cheryl, but about volunteerism and community engagement. There is an opportunity for you to do that as part of an overall curricular professional development goal specific to lifespan. And within our curriculum, there are times that we go out into the community to do screenings or activity promotion events. So an example is we've partnered with Gigi's Playhouse, which is a Down syndrome advocacy organization for families across the lifespan, but we've partnered specifically with their teen fitness program, where you can elect to do this opportunity within lifespan to go do a fitness screening and then to organize a fitness session tailored and towards teens that are coming for a fitness center or fitness class that have Down syndrome. So that's just another example of ways in which volunteering is kind of baked into the curriculum a little bit.
That's wonderful. Thank you so much, Dr. Moulton and Dr. Krosschell.
Thank you so much for your question, Cheryl. And yeah, we do. I recognize a lot of you from the virtual session. Actually, Kristin, Theresa, and Colleen, you'll probably be happy to hear that we talk about Go Baby Go in our virtual session as like an opportunity to volunteer and stuff. So a lot of the students have actually heard a little bit about it, but not super in depth. Again, thanks for your question, Cheryl. Next, we'll go ahead and have Alexa.
There we go. All right. Can you guys hear me now? Perfect. Awesome. I just had a question about how you guys got into teaching and why you picked Northwestern to teach at.
Somebody else can start if they want. I was working at Children's when it was not called Lurie Children's, and it was in Lincoln Park, so it was a little bit further away. And one of the faculty members that taught at Northwestern came 1 day a week, and they were looking for adjunct people to teach. And I just finished my graduate degree. And so I thought, oh, it sounds like a good idea. I'll try it out. So that's how I got interested over time. And then eventually, like I said, made my way from like a little tiny bit to part-time to full-time. That's how that was my route. And Northwestern, just because it was down the street and I had already moved to.
So I never thought that I was going to do research or teaching when I started. I just was like, I'm going to go to be a PT, and I'm going to do PT for the rest of my life. And then I just, we had a residency program, which you guys may or may not be aware of, in pediatrics that started up, and I was really interested in that model. So I started teaching through the residency program there. And then I also started to do research based on just questions that I had myself in the clinic and wanted to learn more about with these infants after they graduated from the NICU. So that launched me into sort of some academic type work, although I didn't honestly even know what that meant when I was a PT. So anyway, for me, it just sort of happened based on my interests when I was a PT. And then I did some teaching as like an adjunct at Northwestern, and we hosted a course with Northwestern, and that's sort of how I got hooked in.
My route is a little bit more traditional. I was sort of raised as an academic in the sense that I was part of the initial wave of dual degree DPT PhD students, and therefore half of my educational experience was part of the like rigorous scientific model. And so I did do some teaching training kind of with a goal to stay in academia in some level. And so a return to my alma mater was like, I was grateful for that. And it was like a homecoming in some ways. But that was my intention through school was probably more towards teaching than what Kristin and Colleen had described.
Awesome. Thank you so much.
Great. Thank you for your question, Alexa. So we'll have Christina's question next.
Hi, actually that was like a perfect transition to my two questions I wanted to ask. So I'm really into like pediatric PT, and I definitely want to do like clinical care, but I also really want to become a pediatric professor. So I was wondering, would you recommend to be like specialized in pediatrics? Would you recommend a residency or fellowship after DPT school? And also, if I did want to teach pediatrics, would you recommend having like a doctorate of education or a PhD, or would a DPT kind of suffice for that?
I think we all have different backgrounds, and we all teach here. So different schools require different things to become a professor. But so I, for instance, have my DPT, and let me just speak for you, Theresa, but Theresa has her PhD. So we all have like different paths, and Northwestern allows us to be professors with our DPT. I didn't do a residency because they weren't really available, but I think that if you know that you want to specialize after you're done with school, it's a nice way to get involved in some sort of teaching mentoring relationship to really focus your career a little bit more on pediatrics in like a structured mentored way. Yeah, but I don't know if you would need that to become a professor, although like the generation of people who are who have had opportunities to do a residency program is probably just coming of age now to the point where that may be an advantage for them. But residencies in pediatrics have only been around for about 10 years.
Yeah, I think I would say I don't think a residency is an absolute. I didn't have a residency either. I have a DPT. I had gotten my graduate degree in motor control and motor learning, so an sort of PT related, but not a PT degree. I think one of the key things was like the way I really started and got interested was by volunteering, when I got asked, and like taking advantage of opportunities to participate or assist in labs, like in the community that I was in, which was Northwestern at the time. And so I think that's how that sort of grew over time. And I think that's how a lot of our adjunct people come into teaching who don't teach full time. They're really interested in teaching. They maybe have had students in the clinic, which is another way to teach. and then they wanted to continue on but teach at a different level and in a different realm. I think there's so many different teaching opportunities, not even just at a university, that I think there's a lot of different ways you can sort of go, and it's sort of just looking for those opportunities as you go along, I think.
Thank you guys so much.
Thanks for your question, Christina. So next, so we're gonna go Mary Kate, Nikki, and then Grace, then Liz.
Hi, thank you so much for having this tonight. I don't know much about pediatrics and physical therapy, so I'm excited to learn more about the program. I have two questions. The first one is in regards to the clinicals within pediatrics. Is there an opportunity to do a clinical within a school setting, or are they more of the at-home setting or outpatient type of clinic?
I think you get there's a pretty wide realm. It depends on which clinical, and like there are some requirements, but Peds isn't like an absolute requirement, but there's school-based settings, there's home health or early intervention, there's clinic-based settings, outpatient, there's acute care, and there's rehab. Like you could get any and all of those in one setting, or just one of those for the whole clinical, depending on, you know, what you chose. I think there's actually we have a really good, really more than adequate number of Peds clinical settings to sort of explore things in.
Awesome. Okay, thank you. And then my other question is in regards to, I guess, cross-functionally, is there opportunity to work with behavioral specialists when it comes to children with special needs? Are those more along the lines of neurological, like cerebral palsy, or do they ever work with, I guess, well, there's the volunteer with Down syndrome, but someone with a behavioral disorder like autism, something like along those lines?
Yeah, I think that's a very good question. We do, our goal is to make every graduate a generalist, and so that they're comfortable treating the movement components, especially of any diagnosis for a child or an adult. Regarding your specific question, we don't have a large component of behavioral interactions in the didactic curriculum. There are a couple of clinicals that I am aware of that live in clinics that have a high autism population, for example. So I can think of one that's a hippotherapy clinic that a lot of the patient population there would have autism, and there is a multidisciplinary team that works at that particular setting. So it's not something that we necessarily have the space to build in that opportunity for every single student, but those opportunities do exist in areas of the clinical education, I would say. And we do touch on behavioral strategies in the didactic portion, but like out of respect for our colleagues that are like really the experts in those areas, I would say that we don't do it justice relative to what their curriculums would do, but we try to at least cultivate an awareness of some basic strategies and principles.
I think the other thing is if you go into a pediatric setting, like for one of your clinicals, like whether it's early intervention or a rehab setting like Shirley Ryan, or, you know, a hospital-based program, like you're going to be working in those settings, more than likely interacting at some level with multidisciplinary teams that usually, for children who need behavioral specialists, you'll probably run into and work with them in that type of setting. It's just not built directly into our curriculum. Good question.
Okay. Thank you. Yeah, I was just curious if you work with occupational therapists or what the relationship was there with behavioral specialists. So thank you.
Okay, awesome. I think thanks for your question, Mary Kate. And we've got Nikki next, did I say?
Yeah, I think so.
Awesome.
Hi, I'm Nikki. My question kind of got answered by Mary Kate's question was kind of similar to mine, but I was just wondering if there were any other opportunities like Go Baby Go that expose students to the collaboration aspect of working with patients with complex diagnoses. So I think that was kind of answered though.
Yeah, I come across, oh, sorry, Colleen, go ahead.
No, I was just going to say that we have also something that I don't think we've talked about, the synthesis projects yet, have we?
Not in detail. No, I mentioned it very briefly.
Yeah, so we have these research projects that we kind of lead, and depending on the year that you're interested in, we all host one. And so, for instance, like part of my current plan anyways, although we've had to go online because of COVID, was to take students into a multidisciplinary NICU follow-up clinic to do some work there. So there might be like some potential in the different research groups to do that. Yeah, one other thing that I don't think we've talked about yet, and it also hasn't quite started yet, but we were just about to do it again before the COVID crisis, was a pediatric special interest group led by the students who are interested in pediatrics, and we have it all set up and ready to go. And maybe we could take that online. I'm just talking out loud now for Theresa and Kristin, because this seems to work quite well, and we could do the same thing for our pediatric research forum. I think we just are still figuring it all out. But anyways, where the students bring forward speakers that they'd like to hear from, and so far they've been interested in hearing from pediatric physical therapists in different specialties, but I could see that becoming, we want to hear from someone that a psychologist, neuropsychologist, and what they do, or other tangential things to pediatrics that people might be interested in. The goal of our special interest group in pediatrics is to listen to students, what they don't get in our curriculum, but they want to learn more about that's related to pediatrics, to bring in speakers that can help address those questions.
I think also we have, I never know the formal name of it. It's called PACE. So it's another project that you're sort of involved in throughout your time, where one of the goals is to do some volunteer activity that helps you to sort of develop yourself professionally. And it's you choose and work with your advisor one-on-one to sort of talk about what your goals might be and what areas you want to develop in professionally. And then you can pick any type of activity in the community to sort of broaden your reach. And even if they are like Peds related, I know students have worked. I have two advisors this year doing something pediatric. One is working in an adaptive dance class with the Hubbard Theater, and then the Hubbard Dance Company. And then I have another student who's volunteered so Shirley Ryan has a program in the summers, which is canceled this year, but this was what she originally volunteered for. Was they do like fitness camps. They're sort of short, later in the day type camps. And we used to embed that within our complex patients course instead of Go Baby Go. But the timing, it's not like in our trimester, the same trimester that elective was in anymore, but there are still students that use that as their volunteer activity, or have volunteered for other types of activities in the community that aren't even PT related per se, but they're related to working with infants and children and adolescents. So those are other ways to sort of get some of that kind of stuff too.
Thank you so much.
And I couldn't remember what PACE stood for, and I just found out yesterday is Professional Advancement and Community Engagement.
That's why I couldn't remember it.
Yeah, I could never remember it. Okay, so now if I remember the order correctly, it is Grace, then Liz, and then we've gotten a couple since then, but we'll go Grace, Liz.
Hi, I was curious as to telehealth's role in pediatric physical therapy, and then kind of to add more weight to that question, how has the transition to remote learning been? Like, what is it? How do you teach PT students how to engage with kids over the internet? Because as a kids yoga instructor, it is really, really difficult to keep their attention in person, let alone over a screen. So any thoughts on that?
I'm going to let Theresa take that.
Okay.
We're co-directors of the lifespan course now, and she's already started thinking about our courses in the fall, how we might manage it. And so
Yeah.
she's probably
So
thought a little more about it than me at this point.
Grace, thank you for this timely question. And I hope that you will forgive our lack of total plan around this particular concept. We've noticed and been really, one of the advantages that we have through the APTA is engagement with other educators in this space. And so we've been trying to, keep up with them and what they're doing. And we know that our colleagues that are in outpatient practice right now have pivoted very quickly to trying to do, these telehealth services. So some of the lessons that we've learned from, I'll speak to the teaching part first. Some of the lessons that we've learned from what we've done so far is that providing flexibility for students is really important, and trying to combine both asynchronous and synchronous opportunities. So acknowledging that you guys are all coming from a different place and a different learning style and different living situations, and that for portions of the content, it may be beneficial to you to be able to watch it twice. So providing some content that is pre-recorded and available on our Canvas, is our online learning platform. But also this back and forth engagement is so critical to learning as well. And so providing synchronous opportunities where we're all in the same time period and actively answering and talking through questions. And so that's kind of how we've been approaching a lot of the didactic curriculum for Lifespan in the fall and thinking about it. We haven't finalized any decisions just yet as we continue to learn over the summer semester with students. The point you bring up about engaging youth and young people is a very challenging one. Even trying to get kids to engage with grandparents and relatives that they're not seeing in person can be very challenging. And so we are continuing to listen to the lessons learned. We think one of the opportunities that exists is empowering of parents to become therapists, essentially, and in a different way than has happened in the clinic. So we traditionally, there's been a lot of techniques where therapists would do something, and whether that was our intention or not, the parents may have had an impression of our magic hands, and not having the confidence to carry that over into the 23 hours a day and times 5 days a week that they're not seeing us, right? And so what we've heard a lot from the boots on the ground, as it were, is that it's challenging, but it actually provides a really interesting opportunity to empower the parents to kind of actively problem solve during a session to figure things out. And, they end up being the more creative ones. And so what we need to know as educators is really think about ways to challenge students to learn some of those skills and to have opportunities to practice. Something that Kristin alluded to is that a really clear thread in our pediatric sequence is a growing ability to interact, first in observation of babies that are there in front of you, and then to a point where we go to a daycare and everybody has their own child to do a screening with. So it's a much more active engagement. That is a clear principle that we build in those opportunities over the course of the semester. So we're honestly, Grace, still working out how that can happen virtually for the number of students in the class, the number of volunteers that we can get to work with us. It's an interesting challenge, and one that I would be lying if I said I wasn't a little bit nervous than taking on, but I think it presents some really nice opportunities for us. So maybe we can check in at open house in January or so about how that's all gone. But I'm relatively optimistic about our ability to be resilient through these challenges.
I also just mentioned that Jessica Trenkel, who's one of our associate faculty that is in a lot of different parts of our curriculum, is actually, so she's an early intervention therapist on the side. And so she sees kids in the home, and she's actually she's been doing telehealth, and she's been talking about those challenges. And in one of our professional role development courses, they're doing a session on telehealth this summer. And I had actually volunteered Jessica to do a case because she sort of got her hands in the middle of it right now. and had just been talking to me like the day before about how challenging it is to even take a patient who's very medically complex and try to teach a family basic range of motion when there's lots of things going on in the environment and you can't really see the foot, and it's hard to tell the family how to work through, increased stiffness. So yeah, it's an interesting thing, but I know that in other parts of the curriculum, they're trying to just wrap in some learning about telehealth. And I think that's really actually an important piece, because I know in my research for all the kids that we've had, I've been very lucky. They're sort of on a flow. So they just started coming back in last week, and I actually went back to the clinic to see them. But the other therapists that I work with at the clinic have been doing all those visits, all those assessments, which I think are even harder, trying to figure out how to do a standardized assessment by telehealth. I've not had to do it yet because I just lucked out that I got to go back in last week when my first kid was ready to come back. So we'll see. I think we're going to be learning as we go. And like Theresa said, ask again in January and we'll probably have some feedback for you or more feedback.
I just want to add to that just a tiny bit. A research project that I've actually been doing the entire time I've been at Northwestern before the pandemic was based on parents providing us information about their babies through an app that they could do at home, because we were already working with fragile, high-risk babies that had trouble coming into the clinic for a lot of different reasons. So I think there's going to be a lot of very valuable things that come out of all telehealth, not just in physical therapy, but all kinds of places that make it more equitable for all kinds of people to access healthcare in ways that they hadn't been able to before. So I hope that we take some of these lessons from the pandemic with us and carry them into the future. And I have done a few assessments virtually so far, and it's a learning process, but I think it'll be very valuable to continue some of this after the pandemic as well. And hopefully we can carry that into the curriculum.
Thank you so much. If there's one thing I've learned from my volunteer hours, it's that PTs are very optimistic problem solvers and embrace all challenges. So I commend you for that. And I will check back in at open house for sure.
Awesome. Thank you so much for your question, Grace. I've now written down the order, so I know for sure. I don't have to memorize it. Liz, you are next.
All right. Hello, I'm Liz. My question is kind of about within the program. So if you are pretty sure that you want to do Peds, following the program, would you recommend kind of almost self-specializing and trying to find as many opportunities through clinicals and other opportunities of having the Peds as opposed to different areas of PT?
I think I would tell you that, we teach you to be a generalist overall, but what I usually tell the students that I advise is that if you're interested in pediatrics, like today, you might be super interested in pediatrics. And I don't want to squash that because I love everybody that wants to do pediatrics. But I also know that people change their minds, and I don't want people to feel I don't want people to get holed into one thing and then feel oh, I missed that opportunity because maybe I really want to do this. And so I feel as you go along, the best thing to do is to keep checking back in and thinking, okay, I still want to do this. I'm still interested. What opportunities are there for me to explore that in many different ways, through those different courses, through community engagement, through just checking in with one of your faculty members to say, hey, is there any opportunity for me I want to see what that might look like in a clinic, to shadow somebody or to talk to somebody about something. I think it's just sort of looking for opportunities. And as faculty, I know we've all been very open and eager to share our experiences and to provide experiences as we can. And because we also have a nice conglomerate of associated faculty that are out in clinics, they also bring in other opportunities and ways that you can interact. I think if you're interested in Peds, I think you absolutely should try and do at least one pediatric clinical. I think they let you do a couple. I don't know how many they let you actually do, but it used to be just one. They actually let you do more than one now. I think you can do several. But I also think that you wanna sort of be familiar with all those other opportunities. And you are going to be required to do some of that. But part of that is anything you learn from your basics or being a generalist, you are going to end up applying to pediatrics. And I think it's also a reason why we don't have lifespan until the second year, is because a lot of those basics that you learn are really going to feed in to what you then get in lifespan. And we're going to be able to sort of build off of what you get in the basics in the first year. There's a lot of back and forth. I think that, learning about infant movement is kind of the foundation to even adult and older adult movement. But I think it all sort of flows back and forth, so.
Okay, thank you.
Awesome. Thanks for your question, Liz. Okay, Mihal, you are next.
Hi, I'm Mihal, and I have two questions specific to early intervention. I know a little bit about what is specific about early intervention compared to regular pediatrics, but I was wondering, is this considered like a subcategory of pediatrics, or do you have to receive a specific specialization for early intervention? Like, how exactly does it differ?
So actually most pediatric therapists are either practicing in early intervention or the school setting. So it's actually the minority of therapists when we look at the group as a whole that are in this acute tertiary hospital care setting, which is maybe where Kristin and I both came from, but not necessarily. Most people are community-based because that's where kids live and that's where they go to school in their community. And they come to the tertiary care center for their surgeries or their special disease care. But, everyday life is spent at home or at school. So EI is a service for kids or early intervention 0 to 3. And it's just the government provides services for children to be seen in their homes or in daycare or wherever they're in settings for the first up until 3 years of age. So that's just sort of how the government provides services for kids that qualify, and the qualifications change based on where you live, and each state is different. I hope you guys have anything to add to that.
Yeah, I think I would agree. It's definitely a subcategory of sort of the larger picture, but I think understanding how to treat somebody and work with them in their community, in their home, is really important. I think we know that a lot better now than we have known in the past.
Mm-hmm. Thank you. And then my second question, kind of going back to what you guys already mentioned. So because I know that early intervention is so common in the home setting or daycare setting, does Northwestern offer clinicals in early intervention specifically, or how do those look like?
Yeah, there's some that are just early intervention, and there's some that are mixed early intervention and school.
And it would be but it would be like in a daycare setting, or you would actually go to the homes of patients?
So in the state of Illinois, early intervention is mostly only covered if you're in a home or a daycare or like a community setting versus, and in most cases, if you're doing a clinical early intervention with a therapist, you're probably going into the homes with them. But a lot of them also might do they might have like a clinic base. And so you might be doing some stuff in the clinic as well. I think sometimes it's mixed in, and then sometimes it's just pure and early intervention.
All right, great. Thank you. That was very helpful.
Just a note on clinicals in general. Not exclusively, but for the most part, you're paired with one clinical instructor so that you have the opportunity to really gain a mentorship relationship with them over the course of the 6 to 13 weeks. And so we see, like Colleen had mentioned, in our colleagues that are practicing, oftentimes there is a mix between either patient populations or treatment settings, especially folks that do early intervention may be in a variety of places. They might be in an outpatient clinic for part of the week and in people's homes another part. So it's not necessarily that a clinical is designed to be a certain split. It just goes along with whoever that clinical instructor mentor is and their schedule. You're kind of going along with that.
Awesome. Thank you so much for your question, Mihal. Okay, so now we've got, we're gonna do Kelsey, Haley, Renee, and then Marsky.
Hi, I'm Kelsey. I was just wondering, So with a larger cohort, how do you go about teaching to different types of learning styles and making sure every type of student flourishes in your classes?
So I can start with that anyways. I think earlier on in the curriculum, I think it's in professional role development or psychosocial, maybe you do like learning style inventories and some opportunities for self-reflection just to help to understand your own needs a little bit better. Like Kristin mentioned, because it's the second year by the time that you get to like where the meat of our classes, we don't necessarily repeat those. Some of the strategies that we use in Lifespan and in other aspects of the curriculum include smaller groups. It is a large class, and so I'd say that large group lectures we try to make that the minority of what you spend your time doing. And even within those, try to find ways to break it up and make active learning really a forefront of our strategy in how we think about the way that you guys receive and process information. I think that there is a lot of work that's put into your ability to communicate and express yourself throughout the curriculum. So I guess this is more personality style than learning style, but natural introverts sometimes find it to be a little bit of a learning process, to be more comfortable speaking up in class, to be more comfortable having dialogues as part of learning. And there's elements of there's still space to be yourself, but that is part of what we see your roles as future physical therapists to do is be effective communicators. And so we try to cultivate opportunities to practice that as well, and maybe small group presentations or chances to like interact with community volunteers, either with or without diagnoses of interest. And then I think the active learning kind of principles is what we try to embed as much as possible so that you guys are doing things more than just listening to things.
And you also get assigned early in the curriculum to what they call a problem-based learning group. So you sort of get assigned to a group that you'll do a lot of sort of active learning with in the first year to learn how to do sort of some group learning, group problem solving, group thinking, and those kinds of things. But then you'll expand out and find that you'll be in a lot of different groups, or like you'll be in pairs for projects. You know, usually the things that are like full class are more lectures or, you know, things that can't really be done in small groups. I think that's why we have a lot of associated Peds faculty, because we do try to really mix up, at least within our course, the learning opportunities that we offer and how we really try to make things in small groups so that we can have richer discussions. And well, sometimes it's great to hear from 90 people. It's also hard to have a really reflective or deep conversation sometimes. And so I think because we know that students sometimes participate and feel more comfortable in smaller groups, we find that those discussions can be a lot more meaningful in smaller groups. So we really work hard to try to manage that and have a lot of opportunities for that. And not just in Lifespan, but throughout the curriculum.
I have to say just one more thing that's maybe timely to this pandemic. You know, on the Zoom platform, we can use polling stuff too. So not everybody really wants to raise their hand and answer a question in front of 96 other people, but people will answer their poll anonymously so we can hear from everybody. And that's also something I want to take with afterwards, because I feel like that's been really helpful because there's lots of different types of learners. But, you know, I think we try to mix it up.
Okay, thank you guys.
Awesome. And so in an effort to get you all out of here by at or around 7, we'll finish off with these last 3 questions that are present. So we've got Haley next.
Hi everyone, I'm Haley and I'm a recent grad from the University of Michigan. I'm really interested in the synthesis project, and I was wondering how many projects available are typically in the pediatrics population. And when you choose a project, does the faculty member leading that project give you the role, or do you get to choose your role?
I think that's a great question. So usually there's probably been on average 2 to 3 a year that are in pediatrics, depending on if we're working together on projects as faculty or if we split up into individual projects. Those are pediatric related. So typically what happens is you would have a choice of projects from across all faculty and from some clinicians that are within the medical center. And you sort of hear about all the projects in different forms each year, it seems, and then you sort of select the ones that would be your priority, and it's sort of a random system that assigns it through some algorithm. But once you're part of our project, I mean, at least the projects that I've done in the past that have been pediatric related, we've usually tried to sort of be very open with the group and let the group try to explore the topic or a part of the topic as independently, of course, with our sort of, mentorship and facilitation, but taking on the roles that, they want to take on and taking on different roles so that you learn about different things, because you basically have to start a project and then bring it all the way through and complete it and then present it at the end, usually at a student poster session. And then we usually encourage people to present it at the APTA combined sections meeting. And then some years you get lucky and your group's been really invested and the pandemic happens. And my group that just graduated actually wrote a paper that they just submitted this afternoon. So sometimes it gets that far where they write a paper and actually submit it. So I'm just excited because we got that off our plate. But if it wasn't for the pandemic, I don't know that it would have happened so quickly. They had free time because they had graduated and finding a job and taking their exams, before they can find a job is sort of, they've had a little bit of downtime. But so I think it's been fairly flexible. We try to let you develop a project with your peers. You're usually in a group of peers, and it can range from anywhere from 2 to, I've seen groups that have had 6 students and some that have just had 2. I don't know the algorithm that they use.
Thank you so much. That was great.
Thank you for your question, Haley. So we've got Renee next.
Hi, I'm Renee. So my question is directed towards Dr. Moulton. So I've been looking at the DPT PhD dual degree program, and I'm kind of curious of how you've been able to utilize the two together, in your professional career.
Yeah, thanks for that question, Renee. And it is sort of specialized question, so feel free to reach out over email. We can chat after this as well. But my PhD is in biomedical engineering, and the overlap between kind of the neural biomechanics side of things that I was focused on in engineering and then clinical practice in physical therapy, I think has worked out really well. So research that I did as a graduate student was sort of biomechanically focused in children with brain injuries and how that changed their neural output. And then for a postdoctoral experience, I went to the NIH and did some signal processing work with a non-invasive neural, or it's an optical neural mapping system called FNIRS, or functional near infrared spectroscopy. And then my line of research now still has a lot of those elements in it, and being just a little bit broader and thinking about bringing in intervention to the story a little bit as well. But I think that the advantage that I feel as an independent researcher is having the full set of tools to answer a scientific question through that training process, but also having the clinical lens by which to ask a question that matters. Because I saw, just to be frank, and this is a safe space for this topic, but I've been to a lot of engineering conferences, and sometimes somebody presents something that is brilliant work, and I'm like, I don't know that math, I could not do that, but the question is ridiculous, nobody cares, good job getting the answer, but sorry, we can't use it. So I think that having both of those hats, I'm biased, but I feel has been very beneficial. But yeah, feel free to connect afterwards, Renee, if that's helpful.
Yeah, and there's also a combined degree with the public health now, right? Is that correct, you guys? Yeah.
Yes. Yep. We've got a
Sorry, well, I'm
DPT
not,
and
it's newer, so I'm not real familiar with it.
yeah, the DPT and Masters in Public Health, which actually this year, since COVID-19 has happened, you know, as a public health crisis, we've gotten a lot more interest with that dual degree too. So yeah, if any of you all are interested in either one of those, let me know in terms of the MPH as well, because I'll connect you to Dr. Margaret Danilovich, who leads that program. And I will be also including all three. So Theresa, Kristin, and Colleen's email address, I'm going to be including in a follow-up email that I'll send to all of you tomorrow. So you'll have that to reach out. So we're going to wrap it up with Marsky is going to have our last question, and then we will all go on our way.
And hi, I'm Marsky, and I have a question. My question is, are there any courses about family education in the DPT program? Because I know that for a pediatric PT, we need to communicate with our kids' parents and help them to provide those healthcare for their kids.
Yeah, that's a good question, Marsky. So I wouldn't say there's a course in that. There is a lot of basics of patient communication in some of the psychosocial course series where parents are certainly considered as one of the listeners. And then that is something that we do focus on in Lifespan quite a bit, just who is your audience, and we focus on treating the whole family. In fact, when you have somebody who's a minor that you're working with, we really think about the environmental factors that they have. If you guys have been introduced to the ICF model, but just thinking about not only the person who's coming to you with the prescription, but like everything around them. And certainly if they're a minor, their parents are generally a very big part of that picture.
Okay, thank you.
Awesome. Thank you for your question, Marsky. And Renee, I didn't get to say thank you before for your question too, Renee. So thank you all so much. You have had some of the best questions I think we've heard. These are some awesome questions. And I was just looking at the sign up sheet, and I think all of you except for one are applying this summer. The application is opening up here in next week. So I definitely look forward to seeing a lot of your applications come through. Again, I'm sending you a follow-up email tomorrow that will include Theresa, Kristin, and Colleen's email address in case you have more questions. But other than that, we'll stay in touch and follow up with us. We'd love to hear from you if you've got anything else for us, okay? Other than that, I wish you all a great night, and we'll be in touch.